Hello, everyone. Welcome to this session today. Our sharing sessions are made possible given the funding support from the Gates Foundation. And my name is Edine Timersma. I'm a senior epidemiologist at KNV Tuberculosis Foundation in The Hague in the Netherlands. Before I start with the introduction of the topic and the speakers for today, I'd like to guide you through a few rules and regulations for this session. First of all, this will be a 1-hour session, and during the session we will have 2 presentations. And after these presentations, there will be Q&A. You can join the discussions through the Q&A button. So you can post any questions or any discussion points there, and we will try to address your questions while the presentations are ongoing. And we will take out a few important questions and topics in the Q&A session so that we come to those. But if your question is not addressed, please take a look at the chat and see if your question is answered there. We do have language interpretation services, so please keep to one of the English, French, or Portuguese channels to get your preferred translation. And our session slides and recording will be shared with you as soon as they are available. So, as I said, we have 2 presentations today, and the first presentation will explain why tuberculosis is difficult to diagnose in children and summarize the currently available global guidance on diagnosing TB in children. The presentation will also introduce stool-based testing for TB and will summarize the progress made with introducing this test globally for routine diagnosis of tuberculosis. And finally, the presentation includes results of a survey that was done among African countries with ASLM to investigate their uptake of stool-based testing and identify potential barriers and challenges. The second presentation of today will highlight some exciting results from Nigeria, where stool-based testing was widely and successfully introduced to help close the gap in the detection of TB among children. And this presentation will show how the introduction of stool-based testing impacted on TB case finding in this group. So Mansa Mbenga and Peter de Haas will jointly present the first presentation, and Nkiru Nwokoye will present the Nigerian example. To briefly introduce our presenters of today. Mansa Mbenga is a clinician and a PMDT expert, and he's also the lead of the treatment and care group here at KNV Tuberculosis Foundation in The Hague in the Netherlands. Peter de Haas is a laboratory expert with over 20 years of experience in TB diagnostics, and she invented the simple one-step stool test for gene expert testing because she was aiming for finding a non-invasive way for a diagnosis of TB among children. And over the past decade, she has developed the test, assessed its robustness and its diagnostic accuracy. And she was also involved in the training of trainers to conduct this, what we call simple one-step stool test. And I was lucky enough to be part of most of these developments. And then last but not least, I'd like to introduce Nkiru Nwokoye, who is the Director of Laboratory Services at KNV Tuberculosis Foundation in Nigeria. Nkiru holds a PhD degree in laboratory sciences and has been involved in implementation of various diagnostic tests in Nigeria since 2010. So I think without further ado, we can start with the presentations, and I will hand over to Mansa Mbenga.
Okay, thank you. So we go to the next slides. So yeah, I will start by taking you through the TB incidence rate. So based on the Global TB Report 2024. So after that, we'll take you through on the diagnostic challenges that we have. And as Edin mentioned, so my colleague Petra will take you through on the stool-based testing. So if we see the Global TB Report for 2024, so you can see that 10.8 million people were ill with TB. So among them, 1.25 deaths. That's in 2023. So, and we can see that for children, about 1.25 million developed TB in 2023, so which is equivalent to 12% of all TB cases. So, and the TB death rates among children is about 191 TB deaths, which is about 50% of all the cases. So, but if you look at it, the highest among children who, as for most of TB, are children under the age of 5 years. So, because of the difficulties of diagnostic and the challenges that we are facing in this age group. So, next. So, and here you can see that the gaps that we have on TB treatment and diagnostic. So, and as I already mentioned, so children under the age of 5 so have the highest. So, and you can see about 51.9% of these age groups have been missing due to many reasons, challenges in diagnosis, and also, accessing the healthcare systems. So, and the other age groups, there is, of course, improvements with diagnostics. Next. So, okay, we understand that there are challenges. So, and these challenges for diagnosing TB in children can be divided into 4 groups. So, and if we look at those different groups, we'll start with the difficulties that we have in the health system. So, and mainly this is the low level of suspicions of TB and TB infections and TB diseases among children. So, and the linkage between the outpatient, pediatric outpatient department and the TB clinics, because always there is a gap in between. So, and the linkage is not very well, and children are not referred on timely basis. So, and the lack of capacity to manage TB in the general or outpatient or the pediatric system. So, if we look at the clinical situation, so what do we have? So, mainly children have non-specific symptoms of TB. So, and these symptoms is always resembled to other childhood disease. So, and it's very difficult for them, and normally they are treated for other respiratory conditions. So, and this normally leads to several treatment with different types of conditions. And whilst TB is suspected, so it will be very late. And normally these children are also seen in the outpatient departments or the primary healthcare clinics, where also the capacity and the awareness of TB is very limited. So, and when we look at the diagnostic tools, so normally there is difficulties of producing sputum, so, and the collection of respiratory samples. So, lack of X-ray. So, and sometimes in certain cases we have stock out of the gene expert cartridges. So, and with all of this come together leads to consequences. So, and for the children, it normally leads to rapid progression of TB disease, so, and leads eventually to early mortality. So, and the delay confirmations of TB and delay treatment initiation. So, and the frequent visiting of different healthcare facilities by the parents will lead also to the catastrophic cost for the family. Next. So, the current WHO recommendations is for TB in children and adolescents is from 2022. So, and in that, WHO recommended the use of sputum, pharyngeal aspirate, gastric aspirate, and stool testing for TB. So, but now with in 2024, so we received a rapid communications from the WHO, so recommending the concurrent use of other respiratory samples and stool testing. So, of course, based on the information that we have from WHO, still we are waiting for the guidelines which will give more information about the concurrent testings. So, and now we will take you through on the stool testing, so which provides more data and improve testing process for children with a high yield of diagnosing TB in children, so which limits the difficulties that we are facing currently. So Petra will take you through that.
Yeah, thanks. And as you said, Mansa, those children had a big gap that is there for the children, the younger age children, the 47% that you mentioned. Those children, they are not likely to produce sputum, but they are, of course, very good in producing stool. And here you see the implementation of the stool-based testing and the technology that we developed. And let me go directly to the next slide to explain a bit more on this method. So just to add to the guidance that is there from WHO on stool-based testing. So there are two guidelines that are available from WHO, and one is on the model 3 on the diagnosis, and the other one is on the management of tuberculosis in children and adolescents. And already since 2020, stool has been recommended as a potential sample for the detection of TB in children. And it was first only recommended for the MTB-RIF test, but later also on the MTB-RIF Ultra test. And soon there will be a new update in 2025. We're expecting it very soon, where we also receive a better data on the expert MTB-RIF Ultra test, as within the other versions, it was still based on very limited data. And there also you see that it has been improved. So in the other guideline, model 5, you will find the clinical algorithms and also the processing methods. And in the manual, the practical manual that also came out in 2022, there you also find the practical consideration and the indicators that you can use when you are implementing stool-based testing. Next slide. So the stool processing method, you saw already that picture at the beginning, and I will show you a little bit of how simple it is. But as the SOS developed the simple one-step stool method, it's also called the SOS stool processing method. And this method is one of the two methods recommended by WHO. It has a similar sensitivity and specificity that's compared to complex methods. There's no additional supplies that is required than you normally use for sputum expert testing. It's easy therefore also to implement at a low cost, and the lab personnel finds it easy to perform the test. And there's only minimal training required, at least for the lab personnel, as the test is similar, although there are steps that you do a little bit different. And then the method is also shown to be robust and relatively low in error rate and invalid rate, so similar also to the sputum expert test. And if you like to learn more on how we came to this evidence, you can look in the sources that you see here below. So just to show how simple the test is, so the SOS stool method, as I say, it is as simple as sputum processing, although the steps are a little bit different to what you do with sputum testing. So for this one, you add the stool, a little bit of stool, into this little bottle that is provided with the expert cartridge. It's called the sample reagent bottle that contains the buffer. And then you shake it, and you leave it standing on the table for 10 minutes just to incubate and to ensure that the bacteria are killed. And also something happens with the stool at that time. Then you shake it again, and you leave it again on the table for another 10 minutes. And while that during those 10 minutes, the sedimentation will occur, so the feces will go down, and the supernatant will become clean on the top. And then you transfer this clean part, the 2 ml, from the top into your cartridge, and it is working well. So a similar stool processing method has also been now developed for the TrueNut MTB Plus and also on the Expert XDR. And so we turned it around a little bit to the test composition. But if anyone is interested, we can easily share you also with the protocol for those two. Next slide. So just to see what is the uptake of the stool-based testing in the country. So if you here you see the map, the world map, and the countries that are colored in green, they have already a routine introduction of the stool-based testing, where the yellow countries have implemented the stool at selected sites. The orange ones are in the planning phase, and the purple one are the ones that are mainly in the interested in the start of the implementation. Sorry. And so finally, you see, this is also the data that we have received from the countries. And so it might be that it's not completely up to date to what the country is at this moment, because we every time try to update this map with the data we have. And just to show you the results that we obtained from the workshop at the Union in 2023 in Paris, there were the pioneers who were already presenting on their data. And here you can see that already more than 60,000 tests were done by all these different countries. And the positivity rate was 4.9%. And the main driver was Nigeria, who already had done at that moment 52,000 tests. And you will hear more of from Neguro on how that evolved in the years after 2023. Luckily, we were also had a workshop at the Union in 2024, which was in Indonesia. And there we were focusing on the Indonesian countries. They are a little bit going on a different pace in the implementation, also because their health system is different from the African countries. But we are really very pleased to see that the implementation of stool testing has evolved so quickly since 2022 till now, that so many countries has already implemented the test. And it also shows that there is a high need for having such a test for the children. And there is a publication that came out during this World TB Day that will present the data that you see here. Next, and also to let you know that there has been a survey on stool-based testing, which is where I will present the next slides on. And so the survey was with ASLM. And so finally, in the stool-based testing, in the survey, we had the aims were to get insights in the pre-filling of the policies, and the strategies and the treatment, but also on the use of the stool-based testing, and also on the assets where they are, the barriers that they had, but also to create an inventory on the type of support needed to address these barriers. So I will go to the next slide. And just to tell you on the survey process, so we prepared questions, and you might have seen those questions because some of you probably has filled out this survey because these were sent to every country. And after the questions were made, we also, of course, reviewed them by ASLM, and we had some country representatives that were checking the questions before we gave them to the external experts and stakeholders representatives, where after we came up to a final survey, and the final survey was translated into French and Portuguese and was sent to the countries. Next slide. So in total, we were able to contact 47 countries, and those 47 countries, 35 of the countries have responded. You also saw that in the map that I just showed, had the response of that, but we also go back to it later. And for in total of the LabCop countries, 91% had the response. So I really thank everyone who has been sending in the survey for their participation. Next slide. So just to show some of the results of that survey. So finally, as I said, we were looking into 4 phases. Also, what you saw in the map that I just presented. So the first is the implementation of stool-based testing that has not yet been planned. The other group of countries were the ones that are planning and started the pilot implementation. The third one is the ones that are really conducting the pilot implementation, and the last group is the nationwide scale-up implementation. So that means the countries were already finishing the pilot implementation and already moved into the scale-up implementation. And here you see the results that we received from the countries, you can see that the dark orange ones are the ones that are already in the nationwide implementation, and the light colored are the ones that are not yet planning. And this is, as I said, the information that we received from the countries through the survey that was conducted last year and was summarized in November. So it might be that some of the countries have already moved ahead. But this is what we have achieved. And as I say, we are really pleased to see how much implementation is already happening in the African countries. And this is a real applause for ourselves on this. Next slide. Just to show also what kind of method has been implemented. So I just mentioned in the beginning that there were 2 methods that were recommended by WHO, and one is the optimized sucrose flotation method developed by Tuberculosis, and then the simple one-step stool method that I just mentioned that is from the KNCV. And we see that, as we say, that the simple one-step stool method was the simplest and also can be implemented most lower cost. So we also see that 34 countries so far have been implementing this specific method. So when we asking the question, we also were interested to understand whether the country had a separate technical working group established to lead the pilot implementation of stool testing. And so we categorized them in the group of planning, pilot, or nationwide. And what you can see, if the orange parts are the ones that not have it in development, the yellow one are in development, the green one are completed, and the red one is showing that it's unknown. And there you can see clearly that during the planning phase, of course, everything is in development, where among the pilot phase, we see that there are some that are completed, but there are some of them that have not have a working group in development, and that is even larger in the nationwide group. And that means that a technical working group is, as we know, very essential in implementing to have established when you are implementing new technologies. But this is something that can clearly been worked on. Next slide. So the other question that we asked in the survey is, has the diagnostic algorithm been adapted to include stool-based testing? And so there you can see that, again, that in the pilot phase, quite a number of them already had that completed, where in the nationwide implementation, almost every country had it completed except one. And that's, of course, very important when you start nationwide implementation. You need to ensure that stool-based testing is put in the right position in the diagnostic algorithm. The next slide. So the other question was, have the routine reporting and registration tool been adapted or developed to include stool-based testing? And here you can also see again for the pilot implementation, you see still quite a number of countries were in development. And we were also seeing that that is also still the case in the nationwide implementation, where there you would expect that the reporting and registration tools would have been already been developed and been in place. And even 2 countries were also mentioning that they have not been in development yet. And this is something that worries, because that should have already been done when you start nationwide implementation. Next slide. So also when you look at the request forms for the laboratory investigation, then you see clearly that this tool has not been implemented even when you are in the nationwide implementation. And we know that sometimes these kind of things are moving behind. and it's clear that also here you see that although a large group already has been able to add stool on the request form. And if you then look into whether the stool has been tested in the digital health system, there you see that that there's a variety here, and quite a number of them are still not in development. And also here that's what we also see often when implementing new technologies for diagnostic. It does take time before it ends up in the digital health system. So this is something that we can clearly take a lesson from. So then the question was also which category of people are included for stool-based testing implementation. And what we see here is that most of the countries had the stool implemented for the children, specifically also under 5, but also for the adolescents. And some of them had it only for those that could not produce a good sputum. And you see also that they also included the people living with HIV and the severely ill. So even that stool has not yet been recommended for adults, we do see that quite a number of countries already have put them into their policies, the adults in the policies to allow them to be tested for stool. And also in the countries, that's what we see happening at the moment, is that when we go to the site, some sites tell us that they don't mind if it's a stool or a sputum, as long as we have a sample so we can test it. And that's really a plus that it moves in that direction. So for the cadres of staff that was planned for training during the implementation, we see that mainly the laboratory staff, of course, are trained because it is a diagnostic tool. But with the diagnostic tool on itself, we do need the clinician, of course, to request the test. Sorry. And what we see is that we often lack to train the community healthcare workers and the monitoring of staff. These were the 5 countries that were in the planning phase. And we asked them that question, and then you see indeed they didn't plan to include the monitoring and evaluation staff, and also not the community healthcare workers as much, where we think it is very important to do so. Next slide. So what are the expected or observed barriers to scale up nationwide implementation of stool-based testing? That was the other question. And there you can see, if can you push one more, yeah, that 40% of the countries did not have any barriers, where the lack of sufficient trained frontline healthcare workers is one of the major one that we see if the pilot implementation starts, and also the nationwide implementation. And the other thing that we see is the suboptimal sample transportation. This is, of course, not very much related to the stool testing on itself. It's something that is more on the logistic side in the country, but that's absolutely seen as a barrier for the implementation, next to the lack of sufficient funding. Another thing that is interesting to see is that there's also a resistance from frontline healthcare workers to collect stool. You see that mainly when they are in the planning phase. So when they are in the planning phase, you see that they expect that there is a high resistance. But when you go to the nationwide implementation, the countries are reporting that this resistance is not as much as they were expecting. And that's interesting to see. And the question is, there still need for support in any of the follow-up areas? Then we see clearly that the training is one of the things that they really highlight a lot. When you take this out, so you can see it more clearly, then you see that the laboratory staff, especially in the beginning, in the planning phase, they are really highly recommended to be trained. Where you see that if you go to the pilot and then it becomes clearly less. And that's different from when you look at the healthcare workers. So in the planning, they are not taking into account for the training, where if you look at the pilot phase, they see clearly that this is missed and that they really need to be trained at the same for the clinician. And that also counts for the monitoring and evaluation staff. So as we say, it is important when you start implementing stool testing that you take all the gathers well into account when you do the training. And Nkuru will tell more on the experiences from Nigeria. The next slide. So the take-home messages from here is that stool-based testing is recommended by WHO for TB and rifampicin resistance in children, offering a non-invasive diagnostic option. Stool-based testing is widely being introduced in the African region, also for the adults. More countries face challenges, most importantly with funding and operational support. And the survey underscores the need of the target assistant to address implementation barriers across Africa. I really want to thank you for listening, and I want to acknowledge also the experts who reviewed the survey, and of course all the countries that responded, that filled in the survey, and the teams at the ASLM that we had a very nice collaboration with. Thanks a lot.
Thank you, Petra, for this nice presentation. So once more, just to remind everybody, if you have questions, please put them in the Q&A. We will try to address your question as soon as possible, hopefully still during this session. I think it's now time to move on to Dr. Nkiru Nwakoye from Nigeria to present the example of Nigeria. The floor is yours.
Thank you very much, Liz, for giving me that positive response. My name is Dr. Nkiru Nwakoye. I work for KNCV Nigeria as the Director of Laboratory Services. I'll be presenting the scale-up of stool testing, current status, and experiences in Nigeria. Okay, so my presentation outline is going to be like this. I'm starting with introduction. I'll run through implementation strategies and steps, all down to results and acknowledgements. So by way of introduction, in 2020, Nigeria was reported as a country with the third highest childhood TB burden globally. And it was estimated that 77,000 childhood TB cases exist then. Unfortunately, out of this huge number, we were able to just notify 11%, contributing to 6% of the total TB cases during the same period. When we looked inwards, we found out that this low notification was largely due to underdiagnosis of TB, underdiagnosis of TB amongst the under 5 age group. And a deep dive also so that, just like the presentation we've had so far from KNCV International, it shows that most children with TB find it difficult to produce protein, especially the younger children under 5-year-old. They present first at the primary health clinics, and at these clinics, we have limited skilled personnel to collect respiratory specimens like gastric aspirates. So this was a great challenge for us. So when KNCV got the award to implement lung project from USAID in 2020, it was key to us to address this for the country. So what we did was to convene a stakeholders meeting to elucidate challenges affecting the low bacteriological TB diagnosis and also to offer improvement solutions. So how did we go about this? We felt it would be nice for us to look externally to see what was happening in the globe then. And then we found the SOS method very, very useful to us because it can be done at the lower level laboratories because of the low biosafety implications. And we adopted that as a country. And the first thing we did was to develop implementation documents like the guidelines, the SOPs in collaboration with NTP. We did not stop at that. We also built capacity of our healthcare workers. We conducted a lot of sensitization. We did that using webinars, trainings, YouTube videos, and we introduced childhood TB testing. I'm going to talk more on this in my subsequent slides. Okay, so what was the initial implementation design when we started? Just like I said, it was an award, KNCV award from USAID in 2020 that started this. So it was basically confined to the 14 states where KNCV Nigeria works. And a total of 1,082 health facilities started this implementation. 11 of them were tertiary, 126 secondary, and 945 were primary health facilities. And if you look at the far end of your slide, you will see the implementation stays in green among the over the pink ones. Just to say that this is not just the pictures now. I think we have everything green now. Everybody, all the states and all facilities with gene experts implements stool-based expert testing in Nigeria currently. Okay, so this tells us this is the national guideline, all right, on the use of stool for TB diagnosis in children. I brought this out just to show us that this stool-based expert testing is a national procedure in Nigeria. We actually have it situated, we're situated in our algorithm. You can see this is an extract from the rapid advice on diagnosis and treatment of child and adolescent tuberculosis in Nigeria. The highlighted stool specimen shows that it's an alternative sample for TB diagnosis in Nigeria. Okay, so something that has worked well for us in our TB notification, something that has boosted our TB notification in Nigeria is the engagement of private community and the private sector. You know, the private sector, a good number of persons go to private sector, visit that first when they fall ill. So we don't actually joke with those in Nigeria. And we felt it when we started with the public sector, the government institutions. However, we felt it would be nice to bring those people on board to decentralize testing. So NTP, in collaboration with partners, introduced what we call the National Childhood TB Testing Week, just like I mentioned earlier. This is a week-long activity dedicated to intentionally find TB among children in the formal and informal settings, be it the orphanage homes, the malnutrition clinics, the schools. We do that following massive sensitization, using radio jingles, SPCC materials, and it has been a strategy that has actually created high demand for the test for us, you know. And currently, we don't just confine childhood TB testing using stool in private laboratories. We do that also in public laboratories, we do that also in private. So all public and private labs that have experts, gene experts, conduct stool testing in Nigeria. And in the 14 KNCV states, a total of 221 expert laboratories, 173 public and 48 private currently conduct these tests. If you look at the far end of the screen, these are just the beautiful pictures from children during one of the childhood TB testing week. So one thing that came out very, very critical when Petra was presenting is the fact that we need to have training done. And it's just not just one-off training, we have to have training and retraining because this is basically a new test. So we have to bring everybody on board. And this we have not actually neglected in Nigeria. Initially, training was conducted at the national, sub-national, and facility levels. We, in collaboration with NTP, KNCV, actually conducted a nationwide webinar for different categories of health professionals. That was when we started, be it pediatricians, doctor officers, lab personnel, clinicians, in both public and private laboratories, even the local government TB supervisors. Nobody was left behind. And we did not stop at that. Our training was actually cascaded down to the state level where we have the state's national TB team in collaboration with the partners in those states, organizing a cluster training for healthcare workers in the states. We also know the role of laboratory staff in stool-based expert testing. So the lab staff receive additional hands-on practicals on stool test procedures. If you look at the other side of the screen, you see our mode of training. So we use different approaches. We use laboratory hands-on. We even visit the lab to observe them perform tests, and we correct them if need be. We use community outreach, the meetings, online webinars. Another thing that has worked for us so well is the development of a YouTube video. YouTube video was actually developed at the request of NTP, such that those laboratory staff that were not able to attend physical meetings will be able to fall back to videos and, you know, perform the tests accurately in their own laboratories, even unsupervised. Again, in KNCV and in Nigeria as a whole, we know that sustainability is very critical. And for that, for you to actually sustain an intervention, we need funds. So KNCB, when we started with USAID funding in 2020, but with discussions with IPs, other stakeholders like the NTP, we gradually, transitioned this to NTP. And by 2020, the test was scaled up to other states funded by Global Fund. I'm happy to mention that stool tests have been streamed into the routine laboratory testing by NTP today in Nigeria, and they provide consumables for the stool testing as at when due, and this has actually facilitated our services that we don't have interruptions in services. So this is a data snapshot from stool tests from October 2023 to September 2024. Just as shown, we were able to screen more than over 3 million children using stool for TB, and about 37,000 of them were presumed to have TB. We identified to have TB. That is presumptive TB case among them. And about 99% of them were actually evaluated for TB. If you look down at the disaggregation of this, you see that 57 were children between 0 to 4 years, 57%, that is 21,000, were from children between 0 to 4 years. These are younger children, and it's expected because this group of children, they find it difficult to produce sputum. Even when they do, the sputum usually do not come out as quality sputum, so they come out as negative bacteriologically. So the older children, 5 to 14 years, we were able to evaluate about 15,000 of them. And from all these evaluations, we got over 2,000 TB cases. Again, a large chunk of them from children between 0 to 4 years of age, and 1,960 of them were put on treatment. So this shows us, this is a stool test contribution to TB case detection in children between 0 to 14 years. All right, so the blue bars is the total MTB, from sputum, stool, and clinical diagnosis, while the orange bars are the MTB detected from just stool alone. The trend line in gray indicates the contribution from stool. So from Q1 2021 to Q3 to Q4 2021, we can see our humble beginnings that we are recording between 6 and 8% contributions from stool. We had a spike in Q1 2022 due to massive sensitizations and going to the community to actually drive these tests. And over time, we have stabilized that on Q3 2024, we were still having 16% contribution from stool. And this has been sustained over time till date. So this is the stool test results from inception, that is July 2020, to recently January 2025. I decided to bring this to see how well we have fared. When we started, we started with 22 TB cases from children in 2022, just 3 months of implementation from July to September. And again, before I explain the graph, the number of children whose stool were examined are in blue bars. The red bars shows TB patient diagnosed, and the green one, TB patients put on treatment, and the trend line in red is the TB yield. So when we started, as I said, we started with 22 TB cases from stool, and we gradually rise from 2021 from 501 to 2024 to 2,381. So you can see the contribution and the increments, the efforts and the results from that. In 2025, just from October to January 2025, we were able to detect 509 TB cases. So in all, about 138,358 children, stool from children has been examined, and more than 6,000 evaluated And again, about 6,400 we are seen to have TB and put on treatment. The TB yield cumulatively has been put at 5%. So these are our references. On a lighter mood, I just say I should bring this picture to tell us that in Nigeria, we don't just find TB cases, we also find joy. So this is the football match between NTP and partners, and please don't ask me who won. Our acknowledgement page, we wish to acknowledge our funder, the USID, NTP for their support throughout this implementation, the KNCV TB Plus, our parent body, for the technical assistance given to us. We wish to also say a big thank you to the children and parent giver who participated in this, and the facility staff. I also want to say thank you to my KNCV colleagues. You can see us beautifully arranged to form KNCV letters. They are the ones that actually detected over 6,000 TB cases using stool from those children and placed over 6,000 of them on treatment. They have done so well. So I want to use this opportunity to say thank you to them. And from all of us in KNCV, I say thank you for listening.
Thank you very much, Kiru, for this exciting presentation. Yeah, and thank you all for your active participation. I see a lot of questions popping up in the chat session. You can continue posting your questions, and we will try to answer them as we go. And we can pick out a few questions to discuss live here. So maybe before we move into the Q&A session, it is good for you to know that you can request a certificate of participation. And I hope there is some guidance on how to get that. And can I please ask the presenters to switch on their camera so that the audience can see you while you are answering some of the main questions that pop up? Thank you. So waiting for Petra, who is probably still typing an answer, because I see she's very active in answering questions at the moment. Yes, thank you, Petra. Yeah, there's this issue with the camera, so I hope it will be solved. Yeah, so I see, Mansa, you were already highlighting a question that you'd like to answer live. And that was a question about sharing recent information and someone who wants to have the presentation and related materials of stool testing for Expert Ultra. So can you answer this question? You are muted, Mansa. We don't hear you.
Are you hearing me now?
Yes, we do. Thank you.
Yeah, so as already Petra mentioned, so and in the presentation, so there are some links that you can go and get this information. So, but I think that sharing the materials that will depend our colleagues from ASLM. So maybe they will share the presentations from this session. So based on the emails address that they have on the participant that have registered. Maybe then it will be good for our colleagues from ASLM to comment on that.
So anyone from ASLM who wants to comment on this?
Thank you, Edina, and I can just confirm that the session materials will be shared through our multiple social media platforms and email addresses.
Thank you, Francis, for coming in. Yeah. So another question that I see several times popping up in the chat is a question about the sensitivity of stool testing compared to sputum expert testing or culture. So I was thinking maybe Petra, you can answer that question. And then maybe Nikiru, I was thinking maybe you can also chip in after Petra answers the question of sensitivity and specificity, because I think there's added value of stool testing, maybe also in other respects. But please start.
Yeah, thanks. Yes, yeah, we didn't present on those kind of data that we have, because we were focusing on the survey data. But we can indeed also share another presentation in which we are also showing all this kind of information. With the APHI in Ethiopia, we have done a very nice accuracy study in which we looked into children, and I think it was more than 800 children that were tested, and they were tested on as well as stool as the respiratory samples of the NGA. And what we have seen from that data is that it was 79% of the stool that were the sensitivity of stool. Sorry, the sensitivity of stool was 79% against the respiratory sample, and the specificity is around 99%. And that's also what we have seen in other studies. So when you go into other countries where we have the possibility to compare against the sputum, you see that the percentage is between the 70 to 80% against the respiratory sample. And the specificity is really high. That's also why stool can be very much used as a rule-in test. So if you tested a child positive with the stool, then already you know the child has TB. There's no reason not to believe that. And that's also how the guideline is guiding this. And that's also because of this very high specificity that we have seen. At the same time, maybe Nikuri can add something here. But what I just want to emphasize as well is what we also see is that sometimes you are lucky. Sometimes you're lucky with the stool, sometimes you're lucky with the NGA. So we also see that although stool might be negative and the NGA might be positive, we also see them the other way around. Especially with children that have a low bacillar load, you can be lucky that you pick it up with the NGA, but you can also be lucky that you pick it up with the stool. So taking multiple samples is absolutely of an advantage. And that's also the reason why the WHO now comes with the concurrent testing. And the question still remains whether, instead of doing a stool and a respiratory sample, is as sensitive as doing a stool 2 times a stool sample. So those kind of data is becoming available as well. And I might need to stop here and give the floor to Nikuru.
Okay, thank you, Petra. So you just said it all. So from experience, I agree with you. It's also good for us to have, testing more than one sample, especially when it comes from stool, because one key thing we've also noticed that stool is not homogeneous, just like sputum. So the chances of not picking it when you are picking from a pot is there, all right? But again, for children with high bacillary load, the chances of picking it is there. And over 65 to 70-something percent sensitivity has been recorded, and not just from one study, but from different studies, So stool expert testing is even now, it has actually gone beyond expert. We can also use Truna to do the stool test. So the stool test is actually a very veritable tool or procedure for childhood TB diagnosis. And the sensitivity is relatively high compared to sputum. Petra has actually given us a good background on that. Thank you. Over.
Yeah, thank you, Kiru. And I agree that although the sensitivity may be a bit lower than sputum-based testing, the issue is that stool provides so much more access to people who cannot produce a spontaneous sputum sample. So another question that pops up regularly is the amount of stool to be added, and if scales and why scales are not needed, etc. So Petra, maybe you can answer this one.
Yeah, so what the amount of stool that needs to be tested, we have done on experiments. We have looked into the amount of stool and how critical it was, because what we don't want is that countries are using a scale to weigh the stool. So finally, what we have said is that at the beginning we said it is needed to have like a 0.8% a 0.8 gram of stool. But when we did another experiment, we saw that even 0.3 gram of stool is already sufficient. And so that's really interesting to see that you can pick between 0.3 gram to 0.8 gram, and there was no significant difference within the MTB detection. You know, I think it would be good for us to share you also with this publication so that you can have you can read this through, because we didn't present this as we were focusing on the survey data, but this is absolutely an excellent question, and we can also provide you with the SOP.
Yeah, thank you, Petra. So maybe yeah, we have 3 minutes left. So maybe a question for Mansa. There was an interesting question about is there any effect of, for example, nutritional status, co-infections, etc., that may affect stool testing performance? And maybe this is not only for stool testing, but for any TB-related testing. So Mansa, I don't know, can you maybe answer this question?
Yeah, so yeah, regarding stool testing, so I will start and maybe Petra can add. So because I think that there is no impact on it. So if, for example, what already Nicolo said, that so if there is a high load of bacilli, so which means that it can be picked up from this stool. So, but when it comes to, you know, other diagnostic procedures like for X-ray on HIV, people living with HIV with co-infection of TB, so there might be some impact, you know, on the changes that you can see on the X-ray itself. So, but when it comes to also sputum, so I think that in sputum also you don't have any impact on that. But I will let the lab team to give more information regarding that. Thank you. So Petra and Nikuru, if you can add anything regarding that.
Yeah, I think I can add specifically what we always say: stool should be part of a comprehensive package. You know, it's stool on itself is of course helping in detecting the bacteriological confirmation, but you also need the clinical judgment. There are still children, of course, that still will be detected or will be treated on a clinical judgment, and stool is just adding to this, like sputum testing does, and also X-ray does. So you need to have a comprehensive package. It's not a standalone test. And what we see indeed, as what Edine say, stool has just created a lot of access, because the problem in the countries is that getting a sputum from a child is very difficult, and bringing in stool now also allows us to get the test being done at the lower healthcare center. And that's what we see, and that's where we see that we are able to check many more children than we were able to do before. And that's where I think the main power and the success of stool is that it can be done at this lower healthcare center. And then, of course, children that are testing negative, they will go up to a higher level, and will have more clinical judgment, probably from a child, from a pediatrician. So I hope that this is clear.
So Petra, as we have now reached the end of the session, we are at 3 p.m. sharp. I think this is a very nice closing remark. Questions continue to be raised. We will try to answer all of these. Is there anything I still forgot to say from ASLM, from the ASLM people? Anything about the certificates or the poll?
We are good, Edina. Thank you so much for a wonderful moderation and a session that you've handled quite well. And like you've indicated, we'll be sharing the questions with the presenters so that we can get a comprehensive response. And that document will form part of the resources that we'll be sending out. My colleague Fitsam has dealt with the question on the the certificates in the chat, and whoever may be interested can look up the response in the chat. Thank you again very much, Bettina, and let me introduce you to just close it. Thank you.
Thank you. So thank you all for your participation, and I hope this was an interesting session. Yeah, I hope also that we will be able to answer all your questions. Thank you all.
Bye.
Bye.